Hello, my name is Katrina George, and I'm a certified nurse midwife and IPCOC practicing in Charlotte, North Carolina. My clinical teaching plan is being done for Baby and Company, a freestanding birthing center, and my topic is improving the screening and management of perinatal depression. I sincerely hope you enjoy my presentation. I look forward to sharing it with you. And on that note, I'm going to go ahead and share my screen. Great. Perinatal depression is the most underdiagnosed obstetrical complication in the United States. Between 14 and 23% of all pregnant women are estimated to experience a depressive disorder. The annual cost of untreated maternal depression in the United States is a whopping $5.7 billion. And that's when only taking into account the decrease in work productivity and absenteeism. As a huge surprise to me, maternal suicide surpasses hemorrhage and hypertensive disorders as a leading cause of maternal mortality. During labor, mothers with poorly managed depression are more likely to have dysfunctional labor patterns and uncontrolled pain. The effect of maternal depression infiltrates into fetal well-being by significantly increasing the risk of preterm birth, low birth weight, and intrauterine growth restriction to the same risk as a woman who smokes 10 or more cigarettes per day. In addition to this, it may impair a child's cognitive, social, emotional, and behavioral development. Maternal depression has further implications to the child. It has been linked with reducing breastfeeding rates, duration, and levels of immunoglobulin A. The American College of Obstetricians and Gynecologists, the American College of Nurse Midwives, Mental Health America, and the United States Preventative Service Task Force all recommend routine screening for depression perinatally. A chart audit of 20 patients revealed that the birthing center screened 0 of their patients at their initial visit, transfers into care, third trimester, and high-risk patients seen at 2 weeks postpartum. They did, however, screen the majority of their patients at their 6-week visit and only 44% between 14 and 16 weeks of pregnancy, which was their standard. In an anonymous survey, 10 patients were asked if they would disclose to their midwife that they were depressed if she didn't ask. A score of 3.4 out of 5 was obtained. I find that very sad. We'd want our patients to be a lot more confident in our ability to care for them. And an anonymous survey of midwives for the statement, and I quote, "Our center has clearly articulated a process for managing depression," end quote, 6 out of 7, or in other words, 85.7% of midwives said they disagreed. I chose this learning need because according to the March of Dimes, 90% of all mothers with postpartum depression could be successfully treated with proper attention and management from providers who are sufficiently educated in this subject matter. This educational lesson was designed for 7 certified nurse midwives and 8 registered nurses. All of the learners are proficient in reading and writing. Demographically, all of the learners are female and between the ages of 25 and 39. And the race and ethnic background does not actually represent the racial diversity in Charlotte. Charlotte tends to be a lot more diverse than what are the makeup of the practitioners and nurses. However, as much as this may pose an indirect and unintentional bias towards the provision of care, I don't think it would impede the providers and nurses' ability to learn. So the goal of this in-service at Baby and Company Charlotte is to improve provider understanding on how to manage perinatal depression. And so by the end of the learning session, 75% of providers will correctly demonstrate how to utilize a depression management algorithm to implement the appropriate care. And so objective 1 is that the providers will be able to accurately input 3 mock patients into a depression case management log. Objective 2, the providers will be able to accurately identify which of the 3 mock patients warrant referral for additional psychiatric care. And for objective 3, the providers will be able to analyze the mock patient's Edinburgh postnatal depression score screening and accurately identify which patient would benefit from cognitive behavioral therapy. And so my method of instruction was simulation. And simulation is a method of instruction that replaces or amplifies real experiences with guided experiences. It does so in order to evoke or replicate realistic scenarios in an interactive manner. This method of instruction works by helping to recreate vivid clinical situations that a student may not otherwise have an opportunity to experience. It helps in practicing and applying their knowledge, clinical skills, and critical thinking. And lastly, simulations help to build the student's confidence in managing real-life situations. So let's review 4 studies that have been conducted on simulations as a teaching method. So for study 1, it was published in 2018. It is a meta-analysis and therefore a level 1 of evidence. 19 studies met the inclusion criteria and focused on experimental studies in which the effectiveness of simulation-based interventions in recognizing and/or managing clinical deterioration was tested. The authors concluded that simulation-based interventions have a positive effect on knowledge and performance. Study 2, conducted in 2015, was also a meta-analysis and a level 1 of evidence, and 20 studies were included in the final analysis. This study explores the effectiveness of patient simulation in nursing education, and it concluded that simulation education demonstrates a medium to large effect on learning. The article also concluded that its findings may be used to guide nurse educators in determining under which conditions patient simulation is more effective than traditional learning methods. And for study 3, which was a randomized controlled trial, and therefore a level 2 of evidence, it was conducted on 421 second-year medical students. The study compared empathic VR's virtual human simulation compared it to standard computer-based learning. And all in all, the study concluded that the empathic VR's virtual human simulation was effective in training advanced communication skills and enabling knowledge transfer into a more realistic clinical situation. In addition to this, students actually preferred the empathic VRs over computer-based learning. Lastly, for study 4, it was an empirical and quantitative study that was conducted also in 2015 and was a level 3 of evidence. And for this study, 550 nursing students are recruited from the 2-year associates and 4-year RN bachelor's program of a university in central Taiwan to participate. The objective was to determine the validity of simulations as a learning theory. They broke it up into 2 phases. For phase 1, questions were developed based on the literature review, and the psychometric properties were evaluated using exploratory factor analysis. For phase 2, it was conducted to evaluate the reliability and validity of the finalized inventory using confirmatory factor analysis. And the study concluded that simulation learning effectiveness inventory is reliable and valid for measuring student perception of learning effectiveness. So the take-home message from the literature review is ultimately that learning is usually best achieved when it is interactive. Simulation training enables knowledge transfer into realistic clinical situations, and it is reliable in measuring student learning. The studies had several things in common. All of the studies confirmed that simulation is an effective teaching method. They demonstrated that simulation improves student and practitioner performance. And lastly, they identified that learners prefer simulation teaching over traditional teaching methods. And there were a couple differences. There's differences in the level of evidence. There were 2 meta-analyses, 1 randomized controlled trial, and 1 quantitative study. There were different populations that were looked at during these studies: nursing students, medical students, and practitioners. And lastly, the study location varied for a couple of these studies. So for the meta-analysis of the studies, they were conducted in the they pulled information from studies conducted in the United States, United Kingdom, Australia, China, and Korea. And one of the other studies were done in Taiwan. All right, so my personal philosophy is that learning is the culmination of past experiences, repetition, associations, and feedback from one's environment. Teaching is not just the ability to impart knowledge on others, it is the art of doing so in a manner that fosters intellectual creativity and cultivates understanding through unique and personal associations. My personal philosophy falls in line with constructivism. By using simulations as a method for teaching, students will be able to learn by actively engaging with the information that they have received. They will also learn through their engagement with other students. And all of this new information will help them assimilate with their new experiences with their old ones. And lastly, students will be able to accommodate by reframing their expectations and understanding of previous preconceptions. And so, as illustrated by the research articles presented previously, simulation is an effective method of instruction that has been demonstrated to be appropriate for students and medical professionals. And so, the targeted audience of this presentation has at least a bachelor's degree in the science of nursing. All right, so the content of all of the objectives will be presented in a PowerPoint presentation with video demonstration, and a handout with bullet points will be included and provided prior to the start of the simulation. Learners will be able to use all of that information during the simulation. The entire learning session will last about an hour. 15 minutes of that will be spent covering all of the material, with 5 minutes being allotted for each of the 3 objectives. And there will also be 3 simulations for learners to get to apply their knowledge and test their understanding of the material. Each of the simulations will run for 5 minutes. And after each simulation, we'll debrief for about 5 minutes. And at the conclusion of all the simulations, we will engage in a group discussion. So let's put it all together by revisiting my 3 objectives. Objective 1, the providers would be able to accurately input 3 mock patients into a depression case management log by the end of the education session. This content will cover the importance of a case management log for tracking patients and ensuring that the right care is being administered. Learners will also be shown how to add the appropriate patients to a case management list. All right, so for objective 2, by the end of the education session, the providers will be able to accurately identify which of the 3 mock patients warrant referral for additional psychiatric care. This content will provide learners with information on when a referral for additional psychiatric care is warranted. An algorithm for this will also be provided. And that algorithm would be through the Massachusetts Child Psychiatry Access Program. All right, and for objective 3, the providers will be able to analyze the mock patient's EPDS screening and accurately identify which patient would benefit from cognitive behavioral therapy. The content will provide learners with information on how to interpret an EPDS screening and appropriate options for cognitive behavioral therapy based on their scores. And again, an algorithm for this will be provided. All right, so there are several ways in which I'll be able to evaluate student learning. The most obvious one is that learners will be able to demonstrate their comprehension through the simulation, through the debriefing, and during the group discussions. In addition to this, I will evaluate the learners by having them take a case study post-test using 3 mock patients. The learners would be asked to score each of the patient's EPDS screening, then input the patients into a depression case management log as deemed appropriate. Then the learners would need to identify which patient would benefit from cognitive behavioral therapy and referral for additional psychiatric care. Here is the form that each student would complete to evaluate the presentation. And so, using a Likert scale, each of the questions would be answered selecting whether they strongly disagree, are neutral to the question, they agree, or strongly agree with each statement. And here are some additional resources that the learners and their colleagues may find very, very resourceful. And here are my references. Again, I want to thank you so much for joining me for my presentation. I hope you found this interesting, and maybe you may choose to use this for a future learning objective in the future. Thank you.